mentioned the combination of Lurasidone and Olanzapine in your experience over the last 4 years. I understand this is a naturalistic study that you've been carrying out. How many patients have been there in this study overall?
Well, I reported 67 patients on this combination who had schizoaffective disorder or schizophrenia, about twice as many people with schizophrenia as schizoaffective disorder. But we all have done this since I did the analysis for that study in a number of other patients. So I've treated probably over 100 patients with this combination in the last 4 years and 4.5 years. And 85%, over 80% of the patients stay on the combination once we've had some even minimal effect. It tends to be a tolerable combination. We do have to do the metabolic blood testing, as one has to do for all antipsychotics, particularly if Olanzapine is in the mix. But it does appear to be well tolerated by patients and appreciated because of its efficacy.
Okay. And what would be the metabolic side effects are something that would need to be monitored because of Olanzapine. Yes. Is there any difference in the metabolic profile because of the combination as opposed to being on Olanzapine alone?
Well, if we, I can't say this completely because I don't have enough numbers, but my impression is that if we start the patients on Lurasidone and give them a little lead-in with Lurasidone before adding the Olanzapine, we probably save a few people from gaining weight, but not everybody. So that would be the way to do it, I would say. And otherwise, the metabolic follow-up is the same as for anybody taking Olanzapine or any other metabolically less favorable antipsychotic.
Okay. So to summarize, you mentioned that the doses are approximately Lurasidone 120 milligrams and Olanzapine 25
to
30 milligrams. So for a clinician practically initiating it, what would it look like?
Well, what I would do, let me give you the inpatient initiation and then the outpatient initiation. The inpatient initiation would go very quickly. Again, multi-episode illness. We would start with 40 milligrams of Lurasidone for a few days, 80 milligrams of Lurasidone for a few days, 120 for a few days, and then target 160. And then at that point, we would add Olanzapine. Usually in this group of patients, 10 milligrams would be a fairly safe starting dose. A few days, 15, a few days, 20, a few days, and then start to hesitate. Do we have to go higher to 25 or 30? Because at some point there can be sedative effects, you can imagine, and we also have to be careful for akathisia or Parkinsonism because you have two dopamine blockers at the same time, so you do have to be a bit wary about that. We haven't had very much problem with blood pressure, pulse effects, and certainly no cardiovascular effects in general. Now, as an outpatient, and I've done this many, many times, most of the time I would say in outpatients than in inpatients, we would again start with the Lurasidone and initiate it in the same way, but spread out over maybe 4 to 8 weeks rather than 2 weeks, something like that, just to make sure the side effects were tolerable. And then we'd add the Olanzapine in exactly the same way. The Lurasidone, of course, we would give at supper time to favor absorption, and the Olanzapine almost always at bedtime because of the sedative effect. Right. And then we would target it the same way. By the end of about 12 to 16 weeks as an outpatient, we would be at our target dose.
Okay. It's fascinating you mentioned that because in my personal experience recently I've had a very, very difficult, challenging clinical patient with schizoaffective disorder, resistant illness, had ECT in the past, was on very high-dose antipsychotic medication leading to Parkinsonian side effects. And she responded very, very well to a combination of Clozapine and Lurasidone. At Clozapine 600 and Lurasidone 240 milligrams. And the reason why I chose Lurasidone was its cardiovascular sort of favorable effect. Would it sort of be a similar combination? Any comments on that? This was serendipitous, yes. Of course.
Well, great minds think alike. I am actually doing a study on that. I'm going to report it this fall, where we, but not quite in the way that you're talking about. Because again, for me, when we add a dopamine blocker to Clozapine, we're not sure what's going to happen, because again, even if the response to clozapine is going to be partial in an ultra-resistant case, that's the definition of ultra-resistant psychosis, no or partial response to clozapine only, we're still probably not dealing with a hyperdopaminergic state. Right. So adding a dopamine blocker, it's not clear to me what actually that does in terms of the therapeutic augmentation of the clozapine effect. However, there's another side to that coin, and I've talked about it before, which is clozapine is a very heavy medication to take for patients. A lot of sedative effects. You're sleepy all the time, you feel tired, you're constipated, you're gaining weight, you're having a lot of saliva. And what I found is that by adding Lurasidone to do some of the dopamine blockade, which clozapine does do, I'm able to reduce the dose of clozapine to a level where the patients can tolerate it much, much better. And they then feel that they're much better because they get the clozapine effect without the side effects. So I would see Lurasidone as being very useful in that respect for the reason that you gave, cardiovascular safety-wise, but also perhaps just a little nod to the metabolic favorable side of it as well. And let's not forget the sexual functioning side of it, where clozapine can sometimes be difficult, whereas Lurasidone usually is not difficult at all. In the patients where I've done this, I've treated about 26 patients with the combination of Lurasidone and Clozapine to look for a reduction in clozapine, reduction in whatever side effect we were targeting. And it worked in every case. That approach worked in every case. No patient relapsed. And we had a few patients who said they felt much better on the combination. But for me, it was that much more question that they weren't feeling the side effects, so of course they felt better. So I'm not sure, again, in my mind, whether there was a true augmentation effect, which maybe there is in one or two patients, but in general, I think it's just a bringing down of the side effect, which makes the patient feel so much better.